Hello, everybody. My name is Dr. Rajal Shah. Welcome to this two parts prostate didactic lecture series. In the first part, I will talk about the diagnosis of prostate cancer, and we will talk about the histological criteria that you can utilize to make a confident diagnosis of prostate cancer. And in the second talk, I will talk about the grading of prostate cancer. So let's get started. When you encounter prostate needle biopsies, there are three typical critical issues that you have to face. First is recognize the prostate cancer and avoid underdiagnosis or false negative diagnosis. Recognize various benign mimics of prostate cancer and avoid overdiagnosis. And finally, recognize features of a lesion which are not fitting into one of these two buckets and would be referred to as a borderline or atypical to classify lesion. So overall, the diagnosis of prostate cancer is usually pretty straightforward, but it can be especially challenging in three situations: when the cancer focus is small in amount, when you have subtle histological variations that can mimic benign lesions, and there are a variety of such conditions which can mimic cancerous conditions which can mimic benign lesions, which I will show you in the next slide. And also in some of the cribriform proliferations, it can be a more challenging diagnosis to deal with. So here is a summary of 5 prostate cancer conditions which are known to mimic as a benign conditions if you are not aware about it and if you do not apply a systemic approach towards the diagnosis. We will cover some of these particular entities during this particular talk. It is very important to keep in mind that these 3 critical issues that you are going to face while interpreting prostate needle biopsies, they are highly interrelated. This is what I refer to as an integrated 3-step approach to prostate cancer diagnosis. And I will talk and emphasize quite a bit about that all throughout my lecture. So there are many histological features which are important for the diagnosis of prostate cancer, but only 3 histological features are considered specific, pathognomonic, or diagnostic of prostate cancer. And these 3 features includes when you have circumferential perineural invasion, like seen in this particular example, when you have mucinous fibroplasia, also referred to as a collagenous micronodules, referring to these intraluminal eosinophilic secretions or plugs within the glands. And then finally, glomerulation, which results from intraluminal proliferation of cancerous cells within the lumen, giving it an appearance of a renal glomeruli. So when you have any of these 3 histological features present in a case, you can make a confident diagnosis of cancer even when the focus is very small in amount. But the day-to-day utility of these 3 features in practice is very limited because of its low incidence, typically seen in less than 10% of prostate biopsies. So in day-to-day practice, what I would emphasize is an integrated 3-step approach towards prostate cancer diagnosis. The first step in this process is a careful low-power assessment of architectural and cytoplasmic details. So in all my whenever you rotate to GU service and work with me, I always emphasize that you screen the prostate biopsy at 4x magnification, use benign glands as your reference point, and then anything which looks architecturally or cytoplasmically different than the benign reference glands, those are the glands that you have to focus further at high magnification to look for cytological ATPR. And the final step before you consider the diagnosis of cancer is to rule out benign conditions that may give you such architectural or cytological ATPR. So this is that 3-step integrated approach, which I will emphasize in my presentation. For conceptual purposes, the diagnosis of prostate cancer is divided into major and minor features. Major features have significant weight and they must be present. At least some of the major features must be present within a lesion to qualify for a cancer diagnosis, while minor features have less weight and they essentially help you to point out that you are dealing with some abnormal proliferation, and then look for major features, and in combination you can make a diagnosis of prostate cancer. But keep in mind that none of these major or even minor features are specific for prostate cancer diagnosis. So when you are dealing with a small focus of cancer, you need a constellation of major and sometimes some minor features to make a confident diagnosis of prostate cancer. So let's review these major features of prostate cancer. Number one is a careful assessment of low power architectural assessment. And the architectural atypia, which is almost diagnostic, or I would say suggestive of prostate cancer, is so-called an infiltrative pattern in which these atypical glands infiltrate in and between around benign glands. So when you see that type of pattern, that is pretty characteristic of prostate cancer. And keep in mind that low-grade prostate cancer typically do not produce stromal desmoplasia. So that is different than a lot of other cancers where you look for stromal desmoplasia as a sign of invasive cancer, but that is usually not present in low-grade cancers. When it is present, it is a pretty bad sign for that particular patient. Some other architectural variations which are also considered infiltrative pattern is when you see atypical glands on both sides of the benign glands, as seen in this particular example. In a very limited number of glands, you also want to do PIN4 stain, and as you can see here, these atypical glands lack basal cells with strong AMSER expression, supporting the diagnosis of minute cancer. When atypical glands grow the entire width of the core, that's also considered almost an infiltrative architecture. And again, it is shown here in this beautiful example of PIN4 ERG stain, which I will talk a little bit later on during my presentation. There are certain architectural patterns which are abnormal, but they are not necessarily suggestive of prostate cancer. Crowded glands can be seen with cancer as well as many other benign mimics of prostate cancer. So when you have this type of architectural atypia, you do need a lot more other major features to make a confident diagnosis of cancer. Another very important abnormal architectural pattern is when you see atypical cells growing in cribriform pattern. Cribriform refers to as a sieve-like or net-like pattern in which you have multiple holes, punched out holes within the luminal cellular proliferation. So when you see this type of dense atypical cribriform proliferation, you typically have to consider two entities in your differential diagnosis: cribriform Gleason pattern for prostate cancer, and then intraductal carcinoma of the prostate. So when I deal with this type of differential diagnosis, we will talk more about that during the grading second lecture as well. But I ask myself whether am I dealing with a confluent cribriform proliferation? Am I dealing with irregular infiltrative borders? Am I dealing with perineural invasion or extraprostatic extension? And the answer to that question is yes. Then I can make a more confident diagnosis of cribriform prostate cancer. But if the answer to question is no, then you could be dealing with many other differential diagnoses, and we will talk about that sometime in other presentations in more detail. So here are some examples which I would refer to as an infiltrative examples of cribriform proliferation. Here is a beautiful example of confluent cribriform proliferation. These glands are back to back. They have no well-defined borders or boundaries that you can define. They are very confluent in nature. So this is an example of a confluent infiltrative cribriform glands. When you see this type of example morphology, you really do not need basal cell stain to see that whether you have a presence of basal cells or absence of basal cells. The morphology here is pretty diagnostic. In this example, you see clearly perineural invasion, which would be an evidence of invasive process. So here are some examples of obvious cribriform Gleason pattern for prostate cancer. But in this example, you see these atypical dense cribriform glands, but they are discrete. They are large and expansile. They also have branching character to that. And when you look carefully at the periphery of these glands, you can see some basal cells around them. So this is an example of an intraductal carcinoma. This type of large branching glands is a very, very helpful feature that you can utilize. And as seen here, these glands have intact basal cells around them, and we will talk about the criteria of intraductal carcinoma in next slide. So when you see large expansile atypical glands with lumen spanning cells and preserved basal cells, if it demonstrates any of these four features, either dense cribriform proliferation, solid architecture, marked nuclear atypia in which nuclei are 6 times larger than adjacent benign nuclei, or non-focal comedonecrosis. If you have any of these features, then you can make a confident diagnosis of intraductal carcinoma. But if the lesion lacks these classic features, but still is looking more atypical than standard high-grade pain, then those type of proliferations are referred to as an atypical intraductal proliferation. And again, I will talk about that in some other presentations. This intraductal diagnosis requires any of these four major features. And because of its treatment implication, it is recommended that when you deal with a biopsy type of setting, these specific but not very sensitive features you should look for before you make the diagnosis of intraductal carcinoma. The dense cribriform is defined as cellular mass greater than 50% of the luminal space, as seen here in these two examples, and the lumina may be irregular or punched out like DCIS of breast. There are certain other architectural patterns which are also characteristic of high-grade pattern. When you see this kind of confluent, ragged, infiltrative fuse glands, that is pretty characteristic of Gleason pattern for prostate cancer. When you see atypical cells growing in single cells, files, cords, or nest type of pattern, as seen here in this example, nest pattern, that is also pretty characteristic of Gleason pattern 5 prostate cancer. So those are some of the architectural patterns we talked about. The second major criteria is absence of basal cells. So prostate cancer is typically characterized by lack of basal cells. But this particular criteria, even though it is very important in day-to-day practice, you have to apply it with a kind of practical way. Because you have a difficulty in identifying basal cells on hematoxylin and eosin stem cells. Particularly crush cancer cells and stromal cells may mimic as basal cells, as seen in this particular example. Sometimes benign lesions, particularly partial atrophy, high-grade pain, adenosis, they may have very patchy or absent basal cells, as seen in this particular example of partial atrophy. Some glands entirely lack basal cells, and many glands have patchy or partial basal cell staining. So even though absence of basal cells is the hallmark of prostate cancer, by itself is not diagnostic of prostate cancer. So a very important point to keep in mind when you use immunohistochemistry to make the diagnosis of prostate cancer. Another very important point is that I often see that junior residents tend to spend a lot of time looking for whether I'm seeing 2-cell population or single-cell population within this type of glandular proliferation. But when you have an obvious example of cancer like this, you really do not need to go to high power to prove that you have lack of basal cells. The morphology here is pretty characteristic of prostate cancer diagnosis. So that type of practice in an obvious example could be counterproductive. The third major and very important criteria is nuclear atypia, characterized by nuclear enlargement, prominent nucleoli, and hyperchromasia. So this particular example here is the reference benign gland, and you can see that these glands have an obvious nuclear enlargement, prominent nucleoli. So that another important pitfall to keep in mind that definition of prominent nucleoli is quite subjective. It also depends on the tissue fixation, thickness of the laboratory. So different laboratories would produce a different type of sections with this type of morphology. So in general, nucleoli that are distinct and bigger than adjacent benign glands nucleus, then those are considered as a prominent nucleoli. But I think in general, you really want to see them easily identifiable at 20x magnification to consider that as a prominent nucleoli. But keep in mind that this particular morphology is dependent on the lab. So you have to be comfortable where you are practicing, and you have to adjust your threshold according to that. So here is an interesting case which I encountered in my practice. And you can see here that there are only 5 glands here, but these glands compared to benign glands clearly characterized by abnormal architecture. They appear to infiltrate between benign glands. You can see amphophilic cytoplasm within these glands. So that's another very important feature that I emphasize, and I will talk more about that, is that a very, very helpful feature to pick up small lesions like this. And then you can see that there is obvious nuclear enlargement and prominent nucleoli in these glands compared to this adjacent benign glands. So my diagnosis for this case is Gleason score 3 + 3 = 6, grade group 1. And it is quite okay to do immunohistochemical markers to further prove your diagnosis. But the morphology here is pretty characteristic to call grade group 1 prostate cancer. Sometimes you may not have prominent nucleoli, but if there is a significant nuclear enlargement and hyperchromasia, like an example like this, with the help of immunohistochemistry, you can call minute focus of cancer. But again, I would advise caution that in this type of situation, you want to make sure that you do basal cells stain, or at least PIN4, or at least basal cell stain, to prove further that you are dealing with diagnosis of prostate cancer, and we will talk more about that later on as well. It is also important to keep in mind that certain histological variations, particularly foamy gland cancer, pseudohyperplastic cancer, atrophic cancer, they may look very subtle morphologically. They are characterized by very subtle nuclear or sometimes architectural atypia, and can easily be mimicking as a benign condition. So here is an example of a foamy gland cancer characterized by these very pycnotic small nuclei with abundant xanthomatous or bubbly cytoplasm that you are seeing here. So when you see that type of example morphology, don't get fooled to call this benign. You have to recognize this as an abnormal process. Here in this particular case, you also see adjacent conventional prostate cancer morphology, which is a helpful feature, but it is also important to do immunohistochemical markers in some of this type of setting. Other thing that you can see here, that there is an obvious infiltrative architecture to this morphology. So those other features will help you to make a definitive diagnosis of cancer, even though the nuclear atypia is very, very subtle in this particular example of foamy gland carcinoma. Sometimes foamy gland cancer can have a very poorly differentiated architecture without any obvious gland formation. So in that type of situation, it can mimic as a xanthoma cells. So when you deal with this type of situation, keep in mind that you could be dealing with a poorly differentiated foamy gland carcinoma or alternatively xanthoma type of cells. And it is very important that you do CD68 and cytokeratin in your differential to make sure that you are not missing an important process. So this is an example of a foamy gland adenocarcinoma grade group 5. And you can see that there is a little infiltrative pattern and there is also some gland formation. And otherwise also you see some more pronounced cytological atypia in some of these particular cells. Here is the closer magnification. So we talked about major features. Now minor features, as I told you, they are not very reliable, but they can be very helpful to pick up the lesion at low power examination. Particularly the one that I really am fond of is amphophilic cytoplasm, which I always emphasize all of you that when you look prostate biopsy at 4x magnification, look for the subtle cytoplasmic differences in reference to adjacent benign gland. Prostate cancer invariably should have some degree of cytoplasmic differences compared to adjacent benign glands. And then intralaminal bleomycin, pink amorphous secretions, mitotic figures, crystalloids, adjacent high-grade peen. These are all other soft criteria, and some of that we will talk during this presentation. So here notice that these glands, even though they are relatively limited, they clearly appear abnormal. There is an abnormal infiltrative type architecture. And you can pick these glands more confidently by noticeable cytoplasmic differences in reference to these adjacent benign glands. So pay attention to that cytoplasmic subtle differences to pick this type of abnormal process. Here is what is referred to as a bleomycin. When you see bleomycin of this degree, it is almost diagnostic of prostate cancer. But keep in mind that occasional bleomycin can be seen in atrophic glands. If your section is hyperstained or stained too intensely, you may get some bleomycin in the gland. So isolated bleomycin, you still have to use other features to make a confident diagnosis. Here are some examples of crystalloids characterized by these needle-shaped, prism-shaped structures. And these are very soft criteria because they can be present even in several other benign conditions or even obvious benign prostatic glands. So they by itself are not reliable morphological clue. Here is an example of amorphous secretions characterized by this dense nature of these eosinophilic concretions. Here is an example of stromal retraction. When glands retract to this degree, it is considerably an abnormal feature. But again, this is a soft criteria and you do need other features to make a confident diagnosis of cancer. An important question that you may have is that how many number of glands do you require to make a diagnosis of prostate cancer? And truly speaking, there is no magic number, but in general, it depends on the degree of architectural and cytological features that you have present within lesion. It also would depend on your own experience, own threshold, and particularly in more active surveillance era, we all tend to be a little bit more conservative to apply some of these criteria. And also, it would also depend on the age of the patient. If you see in younger age patient, I would require more number of glands. If the glands have a more those deceptive features of foamy gland or peen-like or pseudo-hyperplastic, atrophic, then you need a lot more glands to make a confident diagnosis of cancer. But in a conventional situation, most urologic pathologists require at least 3 glands to make a confident diagnosis of cancer. So in this particular example, you will agree with me that these 2 glands are clearly atypical. There is an amphophilic cytoplasm that you can see in this gland. There is nuclear atypia, nuclear enlargement, some prominent nucleoli. You see crystalloid as a minor feature. So there are clearly some abnormal features, but the number of gland is insufficient in this example to make a confident diagnosis of cancer. So when you see this type of situation, you have to look at multiple levels to see if the lesion grows. If it stays like this, then even immunohistochemistry likely would not change your diagnosis. In this example, you see this crowded small proliferation of glands with some cytological atypia at the edge of the biopsy. So when you see this kind of crowded mixture of small and medium-sized glands, often we think about adenosis, and when it was stained with PIN4 stain, you do in fact see some rare basal cells within these glands. But note that this particular focus is present at the edge of the biopsy, so you do not have the entire face of the lesion to look at it. So an example like this would be atypical, because you could not exclude cancer because it may still represent adenosis. In this particular example, you see proliferation of small caliber to medium caliber glands with very pale cytoplasm. Note that the cytoplasm of these glands adjacent to reference benign gland is pretty much similar, but there is almost little infiltrative looking architecture type of appearance. And when it was stained with basal cell marker, there was pretty much loss, PIN4 showed pretty much loss of basal cell staining. So even though these glands have a somewhat morphological appearance of partial atrophy, which is an important benign mimic for prostate cancer, you cannot still make a definitive diagnosis because you could not exclude cancer entirely from your differential diagnosis, and this would be referred to again as an atypical diagnosis. In this particular example, you see like large pin-like glands. So these glands are clearly abnormal. They have amphophilic cytoplasm. They have nuclear atypia. When they stained, they had pretty much loss of basal cells with rare basal cell expression and also focal AMSCR expression. So you may be tempted to call something like that as a cancer, but the number of glands was few and it has a pin-like architecture. So you cannot exclude high-grade pin with certainty, and this would be referred to again as an atypical. In this particular example, you have high-grade pin, and in adjacent to high-grade pin, you have this proliferation of small atypical glands. So these small atypical glands may represent a microfocus of invasive cancer, but because you are dealing with so close to high-grade pin, you cannot exclude tangential sectioning or outpouching of these glands, high-grade pin glands, and this would be referred to as what we call high-grade pin with adjacent atypical glands, or pin-atyp, relatively a common scenario that you may face when you come to a service. So distinguish pin-atyp from in fact, high-grade pin with adjacent small focus of cancer can be pretty challenging. It may depend on number of atypical glands, whether you are dealing with a few glands versus numerous glands, distance from the high-grade pin gland, whether they look similar to high-grade pin glands or look dissimilar, and then whether you have any discordant immunohistochemical staining, means the high-grade pin stain is staining with basal cells while the small glandular proliferation entirely lacking basal cells. So if you have all these four features confidently present, then you may be able to call small focus of cancer adjacent to high-grade pin. And here is one such example where you have small focus of cancer glands away from high-grade pin. So it is hard to explain this as a tangential sectioning or outpouching. And this would be referred to as a minute focus of cancer adjacent to high-grade pin. So what we learn is that the atypical gland suspicious for cancer is not a biological entity, but a term that you will utilize to connote uncertainty of diagnosis due to insufficient architectural or cytological features. And there are a variety of terms that have been utilized in practice and in literature. I personally like the atypia or sometimes atypical small acinar proliferation. If it is associated with high-grade pin, I would refer to as a high-grade pin with adjacent small atypical glands. Overall, atypia is the base term because it is encompassing of several other situations. And I think, again, I will skip this particular slide, but I think I showed you that I think this particular diagnosis can result due to a variety of situations where you may have histological features insufficient to establish a cancer diagnosis due to small size, bland cancer features, biopsy artifacts. It may be you may be dealing with a benign lesion presenting with atypical features, such as crowded glands with some mild cytological atypia, atrophy with atypia, pinative, inflamed glands with atypia. So in all of these situations, sometimes you may have to call this atypical because you just do not have sufficient features to make a definite diagnosis of cancer. And sometimes you may be dealing with a confusing immunohistochemistry. It is important to keep in mind that even in the contemporary extended and more extensive sampling type of practice that we are in right now, the significance of atypical gland suspicious for cancer as a predictive marker of unsampled cancer in a repeat biopsy is still significant. Even if you look at it in post-2000 era, it is 40% chance of having a cancer at a repeat biopsy. So most urologists would either do a repeat biopsy within the 6 months, but now we are dealing with more and more multi-parametric MRI screening, not screening, I apologize, multi-parametric MRI imaging technologies. So a patient may be offered MRI, and if there is a lesion, they would definitely do a repeat biopsy within a short period of time. But if there is no lesion in MRI, no Pirates 3 to 5 lesion, then they may opt sometime to follow up this patient with repeat PSA estimation. So this is still considered to be an important diagnosis. Its mean incidence is about 5%, median is about 4.4, and in the contemporary series, there is a lower incidence. But this could be a good quality parameter when you go in practice. If you have atypical rate is less than, significantly less than 5%, then your threshold to call cancer may be too low. But if you have a very high incidence of atypical rate, then your threshold to call something atypical is perhaps too low as well. So I think you have to calibrate this particular, using this particular diagnosis to determine whether you are dealing with a more quality practice type of situation. There can be some histological features that may argue against cancer diagnosis, and these are some of them I already discussed with you, but I will show you some example. When you deal with a low power lobulated architecture, always think about benign first before you consider cancer. When you have small and large glands intermingle without cytoplasmic and cytological difference, think about adenosis or think about benign condition. When you have a pale, clear, atrophic cytoplasm like adjacent gland, think about benign. When you have a random nuclear atypia in which some nuclei look very atypical, but some nuclei look very benign, think about benign condition. And we saw some of these other examples. So here is an example of a beautiful Cowper's glands where you see this beautiful lobulated circumscribed appearance that is, again, very much speaking for a benign diagnosis. And we will talk about some of this benign mimic situation in more detail in some other presentation. Here is, again, always I ask you to keep benign gland as a reference point. So when you keep benign gland as a reference, you can see that these abnormal looking glands, they have identical cytoplasmic and cytological characteristics. So this is an example of an adenosis, but partial atrophy can also have similar pale cytoplasm. But keep in mind that when you deal with this small glandular proliferation, look for this cytoplasmic and these other particular features before you make a cancer diagnosis. Here is a beautiful example of seminal vesicle ejaculatory duct characterized by a random type of cytological atypia in which some nuclei look pleomorphic while some are very small, very benign looking. Nuclei also have a very degenerative type of atypia. You also see lipofuscin pigment. So presence of random type of cytological atypia can be typically seen in two situations, seminal vesicle and radiation atypia. And we will again, as I said, we'll talk more about this topic in detail sometime. Here are the summary of the various markers that have been utilized in practice. Basal cell markers, particularly high molecular weight cytokeratin, particularly CK903 or CK56 and P63 are most widely utilized in practice. They are highly sensitive markers but have a low specificity for the diagnosis. You have to keep in mind that certain benign mimics like partial atrophy, adenosis, high-grade pain will commonly demonstrate patchy positivity or may even entirely lesion lack basal cells. And rarely you may encounter P63 positive prostate cancer. I will show you one example of that. AMSER, again, high sensitivity but low specificity. Majority of high-grade pain, nephrogenic adenoma, and significant proportion of partial atrophy, adenosis, or even benign glands may express AMSER. So you have to have an internal control when you will deal with this type of markers. ERG is a new molecular marker for prostate cancer. It is highly specific but has a low sensitivity, present in only 40 to 50% of prostate cancers. And you have to keep in mind that small proportion of high-grade pain, particularly that intermingle with adjacent unsampled prostate cancer, may show ERG positivity. In my opinion, when I see ERG positivity in high-grade pain or benign gland, invariably you are going to have an unsampled prostate cancer. Again, because of its low sensitivity, I think this diagnosis, this particular marker has not been routinely utilized in practice. But in some high throughput labs, I think we do see use of ERG as a PIN4 cocktail antibody. And keep in mind that these two antibodies particularly are utilized in combination as a cocktail, which is referred to as a PIN4 ERG, like seen in this, PIN4 stain. As seen in this example, you have benign glands showing beautiful internal control, while these atypical glands lack basal cells and there is some AMSER expression. This one also had ERG, which is staining endothelial cells, but cancer was negative, and you can see that there is a little bit overexpression of AMSER even in benign glands. So keep in mind that you need to have this strong internal control before you make the diagnosis of cancer based on immunohistochemistry. You need to have strong internal control before you make the diagnosis. In this particular example, you see these very small atrophic glands with nuclear stratification. So at first instance, if you look at it, these glands looks very atrophic. They in fact look like potentially like basal cell hyperplasia because of the nuclear stratification. But when you look carefully, these glands do have different cytoplasmic characteristic, and most importantly, these glands are clearly very, very infiltrative. You cannot have this type of proliferation all around benign glands, these obvious benign glands, and they have clearly infiltrative architecture. At a closer magnification, you also see clearly nuclear atypia. So there is no doubt that this is an infiltrative atypical glandular proliferation. But because of this curiosity or its resemblance to atrophic or basal cell hyperplasia, somebody may think about doing a stain. And this one was stained with basal cell marker P63 and high molecular weight cytokeratin. And P63 lighted up like Christmas tree, like this example, but CK903 was negative. So keep this in mind that rare prostate cancer may in fact show you aberrant P63 positivity. And this is in a basal cell pattern. So this is not a non-specific staining pattern here, but in fact, prostate cancer, which is expressing basal cell marker P63. So we talked about a lot of limitations, but keep in mind that these markers in certain settings, like when you are dealing with small focus of cancer, when you are dealing with subtle histological variations that can mimic as benign, can be extremely helpful. Here is an example of prostate cancer characterized by these large undulated glands. So at first instance, these large glands look more like benign glands. But if you look at it, these are obvious benign glands, and there is a difference in the cytoplasmic quality of these glands from these benign glands. And in fact, you can see that these glands with differing cytoplasmic characteristics are seen around benign glands. So they are in fact infiltrative glands. You can also see some crystalloids. You can also see nuclear atypia characterized by nuclear enlargement and prominent nucleoli. So they are clearly abnormal process. When stained with pin-4 stain, all these atypical glands lighted up with like a Christmas tree and lack basal cells. So an example like this staining is extremely helpful to make a more definitive diagnosis of cancer. And the diagnosis for this case is prostate adenocarcinoma with pseudohyperplastic features, Gleason score 3+3=6, grade group 1. So I hope that I have emphasized you enough that you need to have this integrated 3-step approach for prostate cancer diagnosis, particularly in more those borderline limited number of atypical glands with certain histological variations or architectural variations. If you have a lesion with architectural atypia, cytological atypia, and you have ruled out benign condition, then you can make a confident diagnosis of cancer. But if any of one feature is absent, then you may have to do more. And before you consider that as a cancer diagnosis, either that may be an atypical diagnosis, it may turn into benign, or sometime in a rare situation, you may be able to resolve that as a cancer with the help of additional workup, particularly immunohistochemistry. So I think keep in mind this 3-step integrated approach, keeping benign glands as your reference point. So in summary, I think the diagnosis of prostate cancer is made using a methodical approach, using constellation of architectural and cytological features, not to overtly rely on one particular feature, particularly when you do not have any of those 3 pathognomonic features of cancer diagnosis. Use benign glands as your reference point. Hesitate to make cancer diagnosis when histological features that argues against cancer diagnosis are present, and we talked about many of those features. Keep in mind that when you use immunohistochemistry, you are using it to support morphological impression. You do not make a diagnosis of cancer just purely based on your immunohistochemistry result. You could be dealing with a lack of basal cells, even in benign glands. That is not enough to call cancer. And you have to make sure that you have appropriate controls are present. And we talked about that in certain histological variations like pseudohyperplastic cancer, foamy gland cancer, pin-like cancer, you would require many glands to make a more confident diagnosis of cancer in addition to those qualitative features. So I would recommend you that in every rotation, I recommend you to this book that I have authored with Dr. Min Zhao. It's a very handy book with a lot of tables, flow charts, easy to follow images. So make that as your guide during that rotation. I also have an educational YouTube channel with many such educational videos available to you at any point, at any time. So please use those. Like if you see a particular condition, you may find video pertaining to that particular topic. I also talk about very simplified approaches to different urologic cancer diagnosis. So it can be a very handy resource for you. So with that note, I thank you for your attention.